Welcome everyone to Health for the World International Grand Rounds. We are really honored to have our Grand Round speaker today. Our Grand Round speaker is Dr. Niky Farid. Dr. Niky Farid is a renowned neuroradiologist, and we are really honored to have her. Dr. Niky Farid is an associate professor in the Department of Radiology at University of California, San Diego. She also directs the MRI Imaging Fellowship Program in the Department of Radiology. Her research is focused on advanced imaging of brain tumors, radiogenomics, and machine learning. Dr. Farid is the Associate Director of Neuroimaging at the Center for Translational Imaging and Precision Medicine at UCSD. She also serves as a neuroradiologist for the Neuro-Oncology Tumor Board at UCSD Health Moores Cancer Center. And Dr. Farid completed her fellowship training in neuroradiology and her residency training in diagnostic radiology at UCSD. She earned her medical degree from UCSD. She's both certified in diagnostic radiology and neuroradiology. Dr. Farid is a member of many professional organizations, including ACR, ASNR, and the American Society of Head and Neck Radiology, among others. Outside of work, Dr. Farid enjoys teaching weekly children's spiritual education classes about the Baha'i faith and community building, which is really beautiful. Thank you so much, Dr. Farid, for taking out time to do this for us, and you can start whenever you're ready.
Thank you so much, Bhavya. I really appreciate the kind introduction. And I'd like to wish everyone, at least here in the West Coast, it's a good morning. So I know we have people from all over the world, which is so exciting. So wherever you are, I wish you a good morning or a good afternoon or a good evening. But thank you all for taking the time to be here with us today. This is my first time speaking for Health for the World, and I'm very excited to do so, and so excited to be involved with this really wonderful organization. And I appreciate the invitation to speak today. So getting right into it here, I will be speaking today on the imaging of white matter disease. I've included a beautiful picture here of the La Jolla coast here in San Diego, just as an invitation for anyone who can come and visit us here in San Diego. We would love to welcome you at UC San Diego. All right, so getting into it, we can think of white matter disease sort of in two broad categories. In a general term, we can think of it as some kind of abnormality of normal myelination of the axons. Now, that abnormality can either be a dysmyelinating process, which means that there's a primary abnormality of myelin formation, sort of a congenital abnormality, versus demyelinating processes, which are a secondary destruction of previously normally myelinated structures. And that's what we will be focusing on today. You know, that's already a pretty broad topic, but we won't be talking about primary dysmyelinating processes in this lecture. And then further classifying demyelinating disorders, we can think of them in four broad categories of autoimmune, infectious, vascular, and then toxic metabolic. And we will look at a few examples in each of these categories. And I'd like to stress, of course, that this is not an exhaustive list. There are certainly others to be included, but I try to include some of the most common disorders in each of these categories. Okay, so we will begin with our review of the autoimmune category, which of course are processes where our own, one's own immune system basically leads an immune response, which destroys the myelin surrounding the axons. So our first case is a 30-year-old female, I'm sorry, 56-year-old female with acute left eye vision loss. So this was a real life case. She came in through our ER, and I've windowed these non-contrast axial CT images in order to sort of emphasize or accentuate the gray-white matter differentiation. And in doing so, you can see that there are a few ill-defined areas of hypoattenuation within the periventricular and juxtacortical white matter. So seeing this in a individual who was having acute left eye vision loss, the recommendation was to proceed with MRI imaging, which was performed. And we can see here that on these axial and sagittal flare images that we have multiple flare hyperintense lesions in the periventricular white matter. And you can see that several of them are oriented perpendicular to the ventricles and to the callosal junction. And these are the have a characteristic name, which we will discuss in a minute. The patient also, because of her vision loss, also underwent MRI imaging of her orbits at the same time. And we can see here on these T2 fat-sat coronal and T1 post-contrast fat-sat coronal images that there is abnormal flare hyperintense signal and associated enhancement within the left optic nerve, which would correlate with her left-sided vision loss. So this lady went on to have a diagnosis of multiple sclerosis. This is sort of a classic imaging appearance of that disease. And the lesions I was referring to are called Dawson fingers. These are the sort of linear or ovoid plaques that are oriented perpendicular to the ventricles or to the callosal junction, as we see here on the sagittal images. It's a sign that's been described for sort of early multiple sclerosis is called the dot dash sign. And that basically refers to sort of alternating areas of linear and more rounded areas of abnormal signal along the callosal septal interface. And again, that's something to look for early on. In this case, this lady obviously had much more extensive disease. And then besides the classic periventricular location, of course, we also look for lesions in the juxtacortical region, in the brainstem, cerebellum, and of course, in the spinal cord. And the updated 2017 McDonald criteria added a couple for multiple sclerosis, added a couple of important sort of criteria that I just wanted to briefly mention. One is that lesions can be counted even if they're asymptomatic. So even if the patient is asymptomatic from the lesions, they can be counted in the determination of lesions that are disseminated in space and time, which of course is a requirement for this diagnosis. And the other important addition was the addition of cortical lesions, not just juxtacortical, but actual lesions within the cortex. Okay, and then just a quick run through of some of the other features that can be seen with multiple sclerosis. Of course, we can look for enhancement of lesions, which indicates that the demyelination at that site is more active or acute, as we see in this case here on this post-contrast image. We can look for this sort of typical incomplete ring enhancement of the lesions. This is very typical of a demyelinating process, not specifically multiple sclerosis, but any demyelinating process tends to have these incomplete rings of enhancement. But of course, that's not always seen, as we can see in this case, where it can be a more nodular area of enhancement. Brainstem lesions are often peripheral, so it's important to look closely at the periphery of your midbrain and pons and medulla. Distinguishing plaques can sometimes be difficult, distinguishing them from sort of the typical white matter lesions that we see with chronic microangiopathic disease, which we will see an example of later. But one of the distinguishing factors is, or features, is seeing lesions close to the temporal horns. When we see lesions close to temporal horns, that's much more typical of a demyelinating process than chronic microangiopathic disease, which we tend to see in older individuals. And finally, we look for these quote unquote black holes. So these areas that appear as T1 hypointense. And these are indicative of areas of actual myelin loss, and is a feature that we see in more severe or long-standing multiple sclerosis. And an interesting feature here is if you look closely, you can see some linear areas within these black holes, and those are the actual venules, because as we know, the lesions with multiple sclerosis typically are perivenular around the medullary veins. And so you can actually see these tiny little veins within these areas of myelin loss. Okay, moving on, still within the autoimmune category, we have a 35-year-old female with acute left-sided weakness. And here we see this much larger area of abnormal flare hyperintensity. It's fairly well defined. It again has that feature that we discussed, that incomplete ring of enhancement seen nicely on the axon coronal post-contrast. And then on our DWI image and corresponding ADC map, we can see that the majority of this lesion, it demonstrates facilitated diffusion. Okay, so most of what you're seeing on this DWI image is actually T2 shine through. However, you can see at the periphery of the lesion, there is some dark signal on the ADC, which is indicative of true restricted diffusion. And that corresponds again to this area of enhancement. So we can see sort of at the leading edge of this lesion, we have enhancement and restricted diffusion. And that's very typical of an acutely demyelinating lesion. And this is a tumefactive demyelinating lesion. You can see that on first glance, one may want to sort of favor a neoplastic process in this case, but it's very, very important to be familiar with this entity of tumefactive demyelination, because you do not want to, rush to biopsy in these cases, and you want to be able to suggest the correct diagnosis. So these are large demyelinating lesions that are typically greater than 2 centimeters. Again, you can see the incomplete ring of enhancement and or restricted diffusion at the leading edge. That's very typical, again, of a demyelinating process. And you can see that there's relative paucity of edema around this lesion, really not much edema or mass effect. That's another hint that this is not a tumor, in which case you would expect to see edema usually and associated mass effect. And then I didn't show you MR perfusion or MR spectroscopy in this case because I didn't have them in this case. But if we did do MR perfusion, we would tend to see low blood volume. However, on MR spectroscopy, the interesting thing is that these tumefactive demyelinating lesions, because it is an area of cellular turnover, you can see elevated choline and lactate peak. So this can actually be quite misleading, again, suggesting a tumor. So it's important to note that the MR spectroscopy of a tumefactive demyelinating lesion can actually mimic that of a tumor. Okay, moving on, we have a 44-year-old male with headache, dizziness, and left-sided paraplegia. And we see here a very interesting lesion with a very characteristic appearance in the right parietal sort of white matter. We can see what looks like concentric sort of circular areas of alternating sort of T2 hyperintensity and T2 sort of iso or hypointensity. Again, on the post-contrast images that we have here on our axial and sagittal, we again see that the enhancement is more confined again to that sort of leading edge, a little more extensive than on the prior case, but again, sort of more peripheral. And again, the restricted diffusion on our DWI and ADC map, again, we see this sort of rim of low ADC, which is really the only area that this lesion is showing true restricted diffusion. The rest of it is predominantly facilitated diffusion. So this is a very characteristic appearance of a specific type of demyelinating process called Balo concentric sclerosis. This is a severe acute monophasic demyelinating process. Patients are usually quite symptomatic. And you see these areas of concentric myelin destruction alternating with areas of myelin repair. And that's what's giving you the sort of characteristic appearance on the T2, this quote unquote onion bulb appearance, like you've have layers of an onion. And again, similar to our tumefactive demyelinating case, you see again this sort of peripheral diffusion restriction and contrast enhancement. Okay, moving on, we have a 28-year-old female with new onset lower extremity sensory and motor dysfunction. And here we're actually starting with imaging of her cord. We'll show imaging of her brain, I believe, as well. But we can see here that in her lower cervical to her upper thoracic cord, we have a really large area of abnormal stir or T2 hyperintensity. There's associated expansion of the cord, and there's associated patchy enhancement within the cord. And just to emphasize, this is different than the lesions we would expect to see with multiple sclerosis. I didn't show you yet an imaging of a typical MS lesion in the cervical cord, but remember that those are usually smaller. They're usually more segmental, usually less than 2 vertebral body heights in CC dimension, craniocaudal dimension. This one is a much more extensive and larger process. So I started with the spine imaging, but if you go back to her MRI brain and orbits from 3 months prior, we can see once again, similar to our first case, that she has abnormal T2 hyperintensity and associated enhancement within her optic nerve, within her left optic nerve. And then I just threw in one representative image from her MRI brain at the time, showing really no characteristic periventricular lesions. So here we have, just to review, a patient that has a large, sort of an extensive process going on in her cervical upper thoracic cord with patchy enhancement. She's acutely symptomatic with paraplegia. And then on her MRI from 3 months prior, we can see this involvement of the optic nerve and really not any significant involvement of the brain. So putting it all together, this is pretty classic for a neuromyelitis optica, which is also known as Devic disease. Of course, we're trying to move away from using eponyms, so NMO is the preferred term. This disease process has a classic triad of myelitis, optic neuritis, and positive NMO IgG antibodies. And these are antibodies against the aquaporin 4 water channel. So that's a very specific finding for this disease process. And I just want to emphasize that brain lesions can occur. So I know in this case we didn't have brain lesions, but they can occur later in the disease process. And when they do, they have a predilection for the periependymal regions, the hypothalamus, and the dorsal brainstem. And again, the NMO IgG has a very, very high specificity for neuromyelitis optica. All right, still within autoimmune, which is sort of our largest category within this sort of demyelinating category, we have an 18-year-old male with new onset sensory symptoms, and his CSF demonstrates a pleocytosis. So we see few sort of geographic areas of abnormal flare hyperintensity. We see a lesion here in the paramedian left frontal lobe, one a little bit more sort of correlating with his precentral gyrus. We have a lesion in the splenium of the corpus callosum. We have a lesion here lower, sort of in the region of the thalamus, and also in the middle cerebellar peduncle. So multiple sort of geographic areas of abnormal flare hyperintensity. Even though these are motion limited images, I did want to show a couple of these SWAN images, which show a little bit of associated susceptibility in a couple of these lesions. And then the patient also had imaging of their cord. And again, similar to our NMO patient, we can see sort of this large segment or longer segment area of abnormal signal, a little more patchy, but again, there's associated expansion of the cord, mild expansion. And then there's also, once again, these sort of patchy areas of enhancement. And the additional history that I will provide now is that this patient had a URI 2 weeks ago. So if we put together their URI 2 weeks ago and then sudden onset of these symptoms and these findings, this is very suggestive of ADEM, acute disseminated encephalomyelitis. Now, you know, just to note that certainly on the very first imaging, it's hard to say if this is going to be a monophasic process or not. And so although we can suggest ADEM, certainly, especially given the history of the URI, ultimately they would have to do follow-up imaging to make sure that these lesions stabilize or resolve, and that the patient doesn't have new lesions. Because again, if you go into more of a process that's going to recur, then you're thinking more of a multiple sclerosis. So some of this is going to be, of course, bringing in the clinical aspects as well. So this is commonly seen in children and teenagers, and often following viral illness or vaccination. Of course, something to think of, especially in our era now of COVID. And the symptoms are usually they have a little bit more systemic symptoms. In addition to the neurologic deficits, they often have an encephalopathy, fever, headache, even seizures. So they have a little bit more of systemic symptoms. And again, monophasic in the majority of the cases, but a subset will progress to multiple sclerosis. So again, the clinical time course is important. And there isn't as specific of a marker as we have with NMO, with the antibody in that disease process, but we can look for anti-MOG or myelin oligodendrocyte glycoprotein, which is seen in about half of these cases. And again, the CSF pleocytosis is also fairly characteristic. And compared with MS, the lesions also are morphologically a little different. They often appear rounder, a little larger, as we saw in our case, and you have more prominent involvement of the basal ganglia, thalami, and brainstem. And we did see some involvement here of our thalami. Again, you can involve the deep gray nuclei even with MS, so that's not a specific finding by any means. And then I really like, now that we've gone through several of these sort of autoimmune sort of demyelinating processes, I really want to put in a plug here for this radiographics article from 2016. I know it's 4 years ago, but still fairly recent. And it's entitled White Matter Diseases with Radiologic Pathologic Correlation. And it's a very nice review of these processes. And I really love this chart that they included, which is a nice chart to really see where the ADEM, MS, and NMO, where they overlap and where they have distinctive features. And so that's a very nice thing to remember, because again, there is a lot of overlap with these processes. With NMO, of course, we again discussed that very specific finding of the antibody. They often have optic neuritis and myelitis. And then with ADEM, you want to look for the history of an infection or viral infection or vaccination, a little bit more of those systemic symptoms that we discussed, younger patients. And then, of course, with MS, the typical sort of Dawson's fingers and the oligoclonal bands in the CSF. So really nice sort of chart to think about those three overlapping processes. All right, so that finishes our sort of broadest category within this sort of overview. And then we will lead now to our sort of infectious. this is, a relatively shorter list, and I'm going to cover sort of just a couple of the main things, but of course know, especially in our era of COVID, that there are certainly, numerous viruses that can cause various, not only white matter, demyelinating sort of processes, but also, other neurologic problems as well. So here we have a 45-year-old male with HIV and generalized weakness. And so here we see this very sort of almost symmetric and confluent process involving the bilateral deep white matter. And remember, I mentioned that this gentleman is only 45. So right away, we also notice that there is volume loss, right? His ventricles are larger and his sulci are larger than we would expect for a 45-year-old. And so this is a example of HIV encephalopathy, and that's it's actually a syndrome of cognitive, behavioral, and motor abnormalities due to the direct HIV effect on the brain. So it's not due to some other opportunistic infection, it's the actual HIV itself. It can occur in about 20% of AIDS patients, and it is a major cause of morbidity. And on imaging, the main things to look for are sort of, again, this global atrophy and this very sort of diffuse and symmetric involvement of the deep white matter. And important to note that none of this white matter involvement is expected to have mass effect or enhancement. And then in contradistinction to that entity, here we have another 55-year-old male also with HIV who is non-compliant with his HAART medication. We know now, of course, with HAART, these patients can have relatively normal lifespans, and the opportunistic infections that we used to see, at least here, in the US. Of course, it's different, across the globe, but at least in the US, the amount of opportunistic infections we're seeing is much less than it was even when I was in training, about 10 to 15 years ago. However, of course, we still have occasional patients who are non-compliant or who are just diagnosed. And so we will see occasionally these opportunistic infections. So here we have a patient who has sort of this multifocal involvement of the white matter. And you can see here, as opposed to some of the other processes that we've seen so far, that this is a process that's really peripheral and is involving the juxtacortical U fibers. This patient also had a lesion in the right middle cerebellar peduncle, and on the post-contrast images, we can see there's no mass effect and no enhancement associated with that lesion. So this is a patient who later went on to be diagnosed with a progressive multifocal leukoencephalopathy, which of course we know is a pretty serious diagnosis and carries a very, very high morbidity and mortality for these patients. And so it's a progressive demyelinating disorder caused by the JC virus, which many individuals have, right, in their many individuals have been exposed to, but this is reactivated in the setting of immune deficiency. And usually it's seen in patients whose CD4s are quite low, usually less than 100. And as opposed to the HIV sort of leukoencephalopathy that we saw in the prior case, which was much more diffuse and much more symmetric and much more involving the deep white matter, this process is more multifocal, patchy, and really has this, again, this characteristic involvement of the subcortical U fibers that we see in this case very nicely. And again, no mass effect and no enhancement, which is true for both HIV leukoencephalopathy as well as PML, usually. And I just want to caveat that I didn't include a case here, but in the setting of IRIS, which is immune reconstitution inflammatory syndrome, you can see enhancement of PML lesions. So it's important to be aware of that one caveat, that in the setting of IRIS, you can see enhancement of the PML lesions. Okay, moving on to our next category. I'm just going to check the time here. We're doing okay. So moving on to the vascular category of these demyelinating processes. We have a young woman who has a known autoimmune disorder, which I have not shared with you quite yet, and she presented with intractable seizures. So you can see again, overlap with some of the other processes that we've discussed, such as, let's say, ADEM, or even the prior case of PML. But in this case, this lady did not have HIV. She was not immunocompromised, but she did have these multifocal areas of abnormal flare hyperintensity. And you can see that it becomes quite extensive and quite confluent within the basal ganglia, thalami, and brainstem, really, really extensive and confluent. And I just included some DWI and ADC images to show that within this large region of abnormality, there are a few punctate areas of restricted diffusion. For example, here in the right gangliocapsular region, and also here in the, left gangliocapsular region, and also in the left midbrain. So there are some small punctate infarcts within this large region of abnormal white matter. And this young woman had a known diagnosis of lupus. And so this is an example of sort of a extensive leukoencephalopathy due to the CNS lupus. So this is an autoimmune vasculopathy. CNS involvement is seen in actually a majority of patients. And on imaging, although you can see focal areas of abnormal white matter signal, in some cases, they can become much more extensive and confluent, as we see in this case of sort of a lupus cerebritis, so to speak. And superimposed on that, because of the underlying vasculitis that these patients have, you can have small infarcts, as we saw in this case. And then also just a sort of a confounding feature is that these patients may have superimposed PRES, or posterior reversible encephalopathy syndrome, which could be due to, let's say, hypertension, because they tend to also, of course, have renal disease. So they can also have a superimposed PRES, which may or may not have been present in this case. Okay, moving on, still within the vascular category, we have a 61-year-old female with headache. So we can see here, and she was previously healthy, no known autoimmune or other problems. We can see here that she has these multifocal areas of sort of rounded flare hyperintensity in her periventricular white matter. So on first glance, it sort of is reminiscent of our first case of, lesions of MS. However, you can see that the lesions are somewhat more rounded. They don't quite have that appearance of Dawson fingers. And on our post-contrast images, we can see sort of this really almost micro-nodular enhancement in this sort of periventricular distribution with several of these lesions. This patient also had imaging of her cord done. Of course, when you see a process that is suggestive of a possible demyelinating process, you want to also image the cord. And so she also had multiple lesions within her cervical and upper thoracic cord. And again, several of them demonstrating enhancement. So of course, multiple sclerosis or ADEM was high, or even a neuromyelitis, optica, those were all high on the differential. However, this patient underwent an extensive workup, including, of course, CSF analysis. She didn't have oligoclonal bands or anti-NMO, so she didn't have any of the features to sort of be suggestive of those processes. And so she actually went on to biopsy of one of these lesions. And so this became a pathologically proven primary angiitis of the CNS. So this brings up a very good point that vasculitis can be a mimic of demyelinating processes. So this is an idiopathic vasculitis affecting the brain and spinal cord. And just to note that to make this diagnosis, really underlying causes of vasculitis need to be excluded first, more systemic causes of vasculitis, such as lupus, for example. But if there's no underlying systemic process, then a diagnosis of primary angiitis of the CNS can be made or can be suggested and proven pathologically. Clinically, most frequently seen in the 5th to 6th decades of life, as was the case in this patient. Headache and encephalopathy are common. And then they have just sort of non-specific elevated inflammatory markers and a high protein level. So nothing really specific in their serum or in their CSF. On imaging, again, the lesions can be really anywhere. They can be periventricular, they can be cortical or subcortical. Patients can have hemorrhages due to the vasculitis. They can also have enhancement, as we saw in our case. And ultimately, I know I mentioned biopsy, but of course, before going to biopsy, a diagnostic angiogram can be performed. Of course, the gold standard is a catheter angiogram, since this is often a process that involves the more distal third-order branches and will not be detected, or may not be detected, I should say, with non-invasive angiography such as CTA or MRA. And again, biopsy may be required to confirm the diagnosis. And then here's a case, not from this patient, because like I said, this patient actually went on to biopsy before getting a catheter angiogram. But we can see here that in this case, from the literature, there are these multifocal segmental areas of narrowing, almost giving you this sort of beaded appearance of the distal sort of third order branches with segmental areas of narrowing and then dilation. And this is a very typical imaging appearance of a vasculitis. It's not specific, certainly, for primary angiitis of the CNS, but just of some type of vasculitis. Okay, still within the vascular category, we have a 40-year-old female with sensorineural hearing loss, vision loss, and confusion. And here, this is one of those times where the history is actually the most important, because the imaging findings in this entity may not always be specific. And again, there can be overlap with other processes. But if you hear that the patient has vision loss and hearing loss and sort of an encephalopathy, that should ring a bell right away of the what this patient ended up having, which we will discuss. But again, we can see here on the axial and sagittal flare images that there are multiple round areas of abnormal flare hyperintensity, once again periventricular, but again, not really giving you that classic Dawson finger appearance. You don't have those sort of perivenular lesions oriented perpendicular to the ventricles. We also have a lesion here in the thalamus. And then I also showed here an image of the midline, just to show that there are several lesions in the corpus callosum itself. Excuse me. And so this patient actually went on to be diagnosed with Susac syndrome. And that's the what I want you guys to think of when you hear of that triad that we just discussed. So it's a fairly rare autoimmune disorder, but it's a microangiopathy is the underlying sort of pathophysiology, which is why I included it in the vascular category. And it involves the brain, the retina, and the cochlea. So it has very specific areas of involvement and therefore very specific symptoms of encephalopathy, vision loss, and hearing loss. So really important to be familiar with the symptoms in this case. And so basically they get sort of microinfarcts in these various locations. Again, we talked about that classic triad. And the lesions, again, a lot of overlap with the lesions we've discussed thus far, but they really do like the deep gray nuclei. We saw a lesion in our case in the thalamus, and they like the corpus callosum, which we showed several lesions here within the corpus callosum itself. Okay, and then here we have a 65-year-old female with memory loss, and I just included this one. This is a very common imaging appearance that we see daily, you know, for those of us who are reading brain MRIs or CTs, these patients that have these, you know, multifocal areas, they can be mild, they can be moderate or severe, but they have these areas in the periventricular white matter, sometimes also subcortical. Oftentimes they're patchy, sometimes they can be more confluent. And we can see that in this case, I also showed you that the patient has an associated chronic infarct in the region of the left caudate with exvacuodilation of the left lateral ventricle. And I also included a swan image to show that she also has multifocal sort of punctate foci susceptibility, likely chronic microhemorrhages. So here we have an older lady. I didn't give you the history that she has hypertension, but she does. She has multiple white matter lesions, old infarcts, microhemorrhages, and this is just the run-of-the-mill chronic hypertensive or microangiopathic diseases that we see every day. And so important to know that we're talking about a lot of entities here, but by far the most common that we're going to see on an everyday basis are these chronic changes, usually in older individuals. Again, extremely common, related to aging and risk factors such as hypertension. And remember, one of the features that I gave, if the patients are sort of younger or middle-aged and there is any question of a demyelinating process, remember that the temporal horns I mentioned, if you see lesions next to temporal horns, that's less, you know, more suggestive that there's another process going on, because you don't tend to get those lesions with your run-of-the-mill chronic microangiopathic disease. But certainly you can get lesions in multiple areas, basal ganglia, corona radiata, pons. And then look for the associated findings. Look for the associated lacunar infarcts. Look for the microhemorrhages. Look for the atrophy to suggest that this patient is older. So, you know, looking for all those associated things helps us make that diagnosis. Okay, and then our final category is sort of this toxic metabolic category. And so we'll discuss, again, there's a lot of entities in this category that I'm not going to discuss, so I'm just sort of sharing a few here. So we have a 47-year-old female with headache. So again, a real life case. She came in through the ER, and so it had CT imaging first. And we can see that she has these areas of cortical and subcortical hypoattenuation in her bilateral occipital lobes. Very much, you know, a predilection here for the posterior cerebral hemispheres. She went on, of course, to have MRI imaging, and we can again see those areas of cortical and subcortical flare hyperintensity and some other areas more anteriorly. In this case, she also happened to have, at least her larger lesion was associated with some restricted diffusion. You can see here there's some low ADC here laterally. Some of it is just T2 shine through. And then within that dominant lesion, she also had a little bit of petechial hemorrhage, as we can see on this axial GRE image. And so the history I didn't give is that she came in, or maybe I did, well, I didn't, headache, but she was also extremely hypertensive. So this is an example of PRES, or posterior reversible encephalopathy syndrome. This is caused by some kind of dysfunction in the cerebrovascular regulation. And it's a little bit of a more umbrella term because it doesn't have one sort of causative etiology, but rather can be associated with various things. Of course, the most common is hypertension, and so that's why sometimes this will be called a hypertensive encephalopathy. But important to remember that you can also see this entity with various chemotherapeutic agents, such as tacrolimus, for example. And then, of course, very important to think of it in patients with preeclampsia or eclampsia. And again, you see these patchy areas of T2 hyperintensity involving the cortex and subcortical white matter. often have a predilection for the posterior circulation or posterior cerebral hemispheres, but they can have lesions more anteriorly as well. And they can also have involvement of the sort of basal ganglia and pons, sort of in a more central distribution. And then usually, although it is by definition a reversible process, sometimes in areas where you sort of go beyond your limits of cerebrovascular regulation, you can get frank infarctions and hemorrhages, as we saw in our case. In the region of her left occipital lobe, she had actually gone on to have some true restricted diffusion and microhemorrhage. And then just a companion case to show that you can have this entity of a central variant press, where you have much more extensive involvement, again, of the brainstem, here the pons, as well as the cerebellum. So there is this central variant press, and we talked about how this can have some overlapping features, for example, in patients with lupus, with sort of a, in the case of like a lupus cerebritis. Okay, here we have a 72-year-old female with altered mental status. And so here we see fairly symmetric areas of abnormal flare hyperintensity involving the bilateral sort of subinsular regions, the thalami, and the pons. On post-contrast images, there's no associated enhancement in any of those regions. And again, a key piece of history I did not share with you is that this patient had been hyponatremic and had come in and had sort of a correction of her hyponatremia. And so this is an acute demyelination caused by rapid shifts in osmolality, classically associated with sort of over rapid correction of a hypernatremia. Even though, so this used to be called, you guys may know it's sort of older terminology, which is central pontine myelinolysis. However, now osmotic demyelination is preferred, because even though the majority of these of this entity involves the pons, there can be definitely extra pontine involvement, as we saw in our case. We saw involvement of the thalami and subinsular region, so you can certainly have extra pontine involvement. And the T2 hyperintensity in the pons classically spares the corticospinal tracts as well as the periphery of the pons. Whoops. And I just wanted to show that here, that you have some sparing sort of the periphery, and also these little owl eyes, which are the corticospinal tracts. So it classically spares those regions. And I believe this is our last case. This is a 20-year-old male who was found down. And remember, we're still in the toxic metabolic category. And so he came in, and of course you can see he has multiple areas of scalp swelling. Try to ignore that. That's, you know, obviously he was found down, not doing well. And you can see this really, again, extensive confluent involvement of his white matter, but a few distinguishing features in this case, which is that he has involvement, first of all, of the corpus callosum, sort of not patchy, but really extensive, the whole corpus callosum, which is somewhat expanded. Involvement of the globus pallidi, very extensive involvement there. Some involvement of the cerebellar hemispheres as well. And then on DWI and ADC maps, we can see that most of this extensive white matter involvement is actually demonstrating restricted diffusion. So really extensive restricted diffusion within that white matter involvement. And this was a case of heroin-induced leukoencephalopathy. So he went on to, of course, have a tox screen, which was positive for heroin. And sometimes you'll hear this term of chasing the dragon. I never quite knew what that meant, but it basically refers to sort of this sort of appearance of a dragon created by the inhalation of the vapors that result from heating the heroin. And classically, you see this really extensive, once again, involvement of the white matter, the splenium of the corpus callosum. The globus pallidi are sort of typically involved, as are the cerebellar peduncles. And much of that white matter demonstrates restricted diffusion. This patient did not have a good outcome. So in summary, let's see. Yes, I've left just a little bit of time for questions, which we'll get to. The summary here is that we discussed sort of an overview of demyelinating processes, which again is a secondary destruction of previously myelinated structures. So we didn't talk about the congenital, adrenal leukodystrophies. That's a whole other talk, hopefully, that you'll get from a pediatric neuroradiologist. And we talked about within each of those categories, we talked about some of the main entities, but again, knowing this is not an exhaustive list. And once again, wanted to put a plug in for that wonderful article and radiographics. The senior author here, as you can see, is the well-known, renowned Dr. Smyrniotopoulos. So I definitely direct your attention to that article. And I thank you so much for your attention. And we will have a few minutes for questions now, but in case we don't get to your question, please know that you are welcome to email me. And my email is right here for any questions or comments. Thank you so much.
Thank you so much, Dr. Farid. That was an excellent and very informational lecture. My name is Rafi. I'm from Los Angeles. I'll be reading off some of these Q&As for you. Here I have a first question from Nana Amawaife. She thanks you for a wonderful presentation, very well simplified. She has greetings from Ghana. The question she has is, when you say monophasic or multiphasic in the autoimmune demyelinating diseases, is it in reference to imaging findings or the disease in general? Oh, I think you're on mute.
Sorry, I had muted myself. Yeah, so very good question. And so remember that the lesions, and I'm actually gonna just go ahead and stop share because I don't think, let's see, so that we can all see each other. Let's see. There we go. So remember that in order to make that diagnosis of multiple sclerosis, there have to be lesions that are disseminated in space and time. And so that can be, is often a clinical diagnosis. But if you see lesions that are disseminated in space and time on imaging, and that's why they get the imaging, then of course that's sufficient for the McDonald criteria. So again, that goes back to what I was saying about lesions don't have to be symptomatic. In other words, the patient doesn't need to have symptoms at time point A and then time point B necessarily. But if they have symptoms, let's say at time point A and they get their imaging, and then at time point B, they get new imaging that shows new lesions, even though they may not be symptomatic, those count for lesions that are disseminated in time.
Excellent, thank you. Here's another question asking, are there typical spectroscopy findings for typical MS lesions? Is it possible to get normal metabolite levels for a few early active symptomatic lesions?
That's a really good question. I don't know too much. I don't know enough about the literature to fully answer that question. I do know, like we discussed, in the lesions that are actively demyelinating and that are large enough to do MR spectroscopy on, because of course you know that the smaller lesions, you may not get enough signal to noise. But if you have a large enough lesion and it's actively demyelinating, then you can definitely get this sort of tumor-like spectrum. And so it's important to be aware of that so as not to go down the wrong path that this is a tumor. But in the, you're asking that if the lesion is not actively demyelinating, can you get normal spectroscopy? And my guess would be yes. But if anyone else on the call, maybe Dr. Bhavya, if you have any additional points on that, please chime in. But my guess would be that if it's a non-actively demyelinating plaque, then you'd probably would get normal spectroscopy.
Here is a question from Jacqueline Perez Ortiz, and it's a two-part question. First part is, what type of vaccine conditions or causes ADEM? And then, is there a precondition in children or young people with ADEM?
Very good question. I think that the MMR vaccine has been the one that I've heard about as most sort of associated with that process. Again, if there's anyone else on the call who knows anything else about that, please chime in. But that's the one I've heard is most commonly associated, but really can happen with other vaccines as well. And as far as a precondition, not to my knowledge, I mean, really the cases I've seen can happen in completely otherwise healthy individuals. So I don't think that there has to be any kind of underlying autoimmune or immunocompromised sort of condition. It can happen in otherwise healthy individuals.
Yeah, sorry I was mute, but I completely agree with Dr. Niky Farid about both things, about the MS spectroscopy findings, being normal and non-active lesions, and also about the vaccine. So I completely agree with her.
Thank
you. Here's a question from Jagadish P. It's a good question. And how to differentiate NMO from MOG by imaging?
That's a good question. I mean, I think once again, on imaging, you may not be able to make a definitive diagnosis. I think if there's a process that is seen that is predominantly involving the cord and or optic nerves, and I want to make that distinction. It doesn't have to be the cord and the optic nerves, it could be cord and or optic nerves. But if there's a process that's predominantly affecting those areas and less so the brain, then I think certainly NMOs should be thought about. And then the other sort of distinguishing feature, which we talked about, is sort of that longer segment involvement of the cord rather than the more discrete segmental lesions that are seen, for example, in multiple sclerosis. So I think, on imaging, you can certainly suggest it and should if there is a predilection for the optic nerves and or the cord. But of course, it will have to be, confirmed with CSF analysis. Dr. Bhavya, do you have anything to add to that?
No, that's excellent. And I was just looking at the time. We are approaching towards the end. So Dr. Niky, just let me read out some really excellent comments about your presentation here. So we have Dr. Ashim Bhatia. He's the president of our Pennsylvania chapter, who says, great presentation. There's a very nice note with a great lecture and thank you from Turkey. Dr. Jamie Conde from Bolivia says, great presentation, thank you. And Dr. Navpreet Khurana says, such a comprehensive and informative session. Thank you so much. Dr. William Ladd says, thank you, Professor Dr. Farid. I am off today, but I set an alarm to be awake for your lecture. And then we have Dr. William Sanson saying, thank you very much. Dr. Adikundu Ekitamunde says, thank you, Dr. Farid, from a great lecture. Dr. Patricia Rodriguez, great lecture. Congratulations, Dr. Farid. Dr. Patrick Nemango, thank you so much for a nice presentation. Dr. Cleenam Zeffiteti, who is the chair of radiology at Kolibu Teaching Hospital in Ghana, is very informative. Thank you. Ernesto Javier, Dr. Ernesto Javier Dena Espinazo from General Hospital of Mexico says, excellent presentation, very good clinical cases. Congratulations. Dr. Cherise Kahizi from Rwanda says, thank you for the nice presentation. There are lots of them, so I'll just read out pretty fast. Dr. Angelina Irock from Kenya says, great presentation, excellent. Dr. Sefia Tefera says, very nice presentation, thank you so much, from Ethiopia. We also have Dr. Amal Sulahi from Ethiopia here, who says, thank you for the great presentation. Dr. Elena Lambert, who is one of the, is in the first radiology residency program in Zambia, says, excellent, very well summarized and informative, and thank you. Dr. Ibrahima Edon from Military Hospital in Ghana says, great presentation. She's the chair of the radiology there and the president of the Radiology Association in Ghana. Great presentation, thank you very much. I'll just quickly see. There are lots of them. So.
Yeah, thank you so much, everyone. Sorry, I was as you were reading, I was also looking at the Q&A box, but I appreciate all the kind comments. Again, this was my first time, so please do give me feedback, because I know that we have, people coming in from all over the world, and there's different levels, everywhere from trainees to, full radiology faculty. So please do give me your feedback. I really appreciate it. Positive and negative would be appreciated, so I can adjust it for next time. And then I also just wanted to comment on one question that I thought was interesting that I saw here is, the question is, what is the best approach for white matter disease investigation in resource-limited countries where MRI is not immediately available? And that's a very good question. I mean, it's absolutely true that we really do rely heavily on MRI, both identifying these lesions as well as distinguishing between them. I think with CT, certainly you can suggest if there's based on clinical symptomatology, if there's a concern, you can definitely suggest it. Like we saw in a few of our cases, we did initially look at the findings on CT, but if you don't have easy access to MR imaging, I would say if there's CT findings that are suggestive, then the patient should, the next step would probably be CSF analysis with lumbar puncture, at least for some of these more common entities. So, but that's a very good question, and we do rely very much on MRI for a lot of these diagnoses.
Yeah, that's a great point, or just to refer to an MRI to a closest referral center, but I completely agree with Dr. Farid, then move on to LP and CSF analysis, All right, I think we are past 8, so I really thank you so much, Dr. Niky Farid, for staying back and, answering these questions. And this was a very impressive lecture. And I think if you see the chat box, it's full of really good feedback about your lecture, so we couldn't read out all of them, but there were maybe close to 100 feedbacks there. So, thank you so much, and we really appreciate this. And you have a wonderful day.
And again, thank you so much to the Health for the World, administrative group for organizing this. I really appreciate Dr. Bhavya for, getting our UCSD chapter involved. We're so excited to be involved in this wonderful organization. And thank you to Rafi for helping to moderate the session and read the questions. I appreciate that.
Yeah, thank you so much. Thank you, Rafi. Thank you, Shama. Thank you, Jose. And thank you, everyone who took our time to join us today for this session. Really appreciate it. And thank you, Dr. Farid. Really, heartfelt thanks. And we'll be in touch. Thank you.
Thank you, Shama. Thank you.